Hello and welcome to this webinar. What I'm going to cover today is pediatric sleep disorders, looking at contemporary diagnostic information and the latest evidence for treatment, which really does feed into our Child and Adolescent Sleep Clinic here at Flinders University. So what I'm going to cover today in part one is really, as I said, looking at the contemporary diagnostic criteria for common pediatric sleep disorders. I guess what we've noticed is that there are some diagnostic systems for sleep disorders that some general practitioners aren't familiar with. So we want to be able to update you with that and then provide the matched evidence base for these treatments, a lot that have been pioneered at our Child and Adolescent Sleep Clinic. So that's going to be the first part, and we will have a link in the video here to the second part, which is really looking at another component of sleep research that I guess a lot of people need some updating with. So this can form another part of your professional development, which is the science behind technology use and sleep in young people. So firstly, just to introduce myself, I'm Professor Michael Gradisar from Flinders University. I'm the director of the Child and Adolescent Sleep Clinic. This was established in 2006, so we've been going strong for the last 14 years. Initially, I was a clinical psychologist working since 2002. Primarily, I was at the Repat Hospital where we had the insomnia clinic where I studied under Leon Lack, and then moved to Flinders to start up my own paediatric sleep clinic. And I've been a sleep researcher since 2002 and an academic since 2005. So I guess I'm juggling a lot of balls at the moment. In terms of other, I guess, major connections that I have, I'm on the Pediatric Sleep Council, which is an international council of pediatric sleep experts. So you can find that at babysleep.com, which is actually quite a good resource to give to parents about information for baby sleep. I've also served as a sleep expert for the National Sleep Foundation in the United States, and also the equivalent here in Australia, the Sleep Health Foundation. I've also contributed to the diagnostic and treatment issues for young people's sleep problems for Headspace in the last couple of years. Also been a consultant for the CSIRO, Vic Roads when it comes to fatigue, Swimming Australia as well, for instance, when they were looking at jet lag plans. So I'm a bit of, I guess, a mixture of different sleep experiences. And I've also been a consultant for different organisations in the USA, Australia and Finland. So first I want to take you through the contemporary diagnostic criteria for teenage sleep disorders. So this is the current version. What I might draw your attention to is over here on the right, which is the International Classification of Sleep Disorders. It's currently in its third edition, and this was released in 2014. And this is the diagnostic system that I guess a lot of people, general practitioners, paediatricians and psychiatrists are not familiar with. It's produced by the American Academy of Sleep Medicine, but it's really, as it says, international, because it's got a host of international experts that have come together and provided a lot more diagnostic criteria for a whole range of different sleep disorders compared to, say, for instance, with the DSM. So particular to teenagers is delayed sleep-wake phase disorder. Previously, it's been known as delayed sleep phase disorder, even delayed sleep phase syndrome. And the diagnostic criteria are listed here. Probably the common ones to really focus on are the first three. So for diagnostic criteria A, there is a significant delay in the phase of the major sleep episode in relation to the desired or required sleep time and wake-up time, as evidenced by a chronic or recurrent complaint by the patient or a caregiver of inability to fall asleep and difficulty awakening at a desired or required clock time. Aside from being a very long sentence, what this means in terms of teenagers is that they're falling asleep late and they are waking up late. And this is really because of a significant biological contributor, which is a delay in their circadian rhythm. And because that doesn't match up well with going to school time, it causes some issues. Criterion B is that the symptoms are present for at least 3 months. And criterion C is when the patients are allowed to choose their sleep schedule, they will exhibit improved sleep quality and quantity for their age and maintain a delayed phase of the 24-hour sleep-wake pattern. So this is commonly seen on weekends where they will fall asleep late and they will also sleep in. But their sleep quantity has obviously increased, therefore the sleep quality has increased and they're feeling much better. So it's really a mismatch between what their biology is dictating and what society is dictating in terms of going to school. Another way to represent it is to really look at this diagram here. And this is something that we actually teach teenagers and their parents when they come in to see us for treatment. So unfortunately, as much as they miss out on school, they still get a science lesson from us. So we focused on the fact that the x-axis is time, and this is across the 24-hour period. On the y-axis, there is alertness, and sleepiness is down here. So we've got a wavy curve here. So the higher the point on the curve, the more alertness is occurring. The lower the point, the greater the sleepiness. And so this is what we would consider a normal circadian rhythm, a normal curve, where we have a bit of a dip in the afternoon, say 2 p.m, and some people might say tend to nap. We actually get a peak in our circadian rhythm about somewhere between 6 to 8 p.m, around dinner time. And that's really because our core body temperature, our internal temperature, is at its peak around that time. Then what happens is that you get the decrease in core temperature. We have the release of heat through the skin of the hands and the feet, for instance. And when we start to have that occur, we also start to feel sleepy. People choose to go to sleep, say, for instance, around here, maybe 10 to 12 o'clock, especially if they're a young person. They don't take much time to fall asleep, but once they're asleep for a significant amount of time. Then the low point of the circadian rhythm is somewhere around 4 to 6 a.m. This is the worst time for us to function. We should be asleep, we shouldn't be up. So this is why it's really unfortunate for shift workers who have to work. But you've basically got poor functioning here in terms of being able to process information and perform things, appetite, all sorts of things. And then about 2 hours later, they start to have an increase in their core temperature and they naturally wake up and they start their day. So that's a normal circadian rhythm. And the good thing about circadian rhythms is that when we go, say, for instance, to travel overseas, so if we're based in Australia, we can go over, say, for instance, to Europe or to the USA, and eventually our circadian rhythms can adapt to that new time zone. But the unfortunate thing is that you can actually be in your own time zone and your circadian rhythm can shift. And this is really demonstrated by this red curve. And this is what we see when we have someone, a young person with delayed sleep phase. So for example, their low point can actually be more so in the later afternoon. And sometimes this can time with when they are coming home from school. So they present with an opportunity to have a rest and they might have a nap. And then what happens is that the peak of their circadian rhythm is more likely, say, for instance, between 10 to 12 p.m. This is when they get their second wind and they feel quite alert at night. Unfortunately, then they will go to bed and they will struggle to fall asleep because this is the most difficult time to fall asleep when you have the peak of your circadian rhythm. Eventually, they will fall asleep. But if you have a look over here, they're forced to get up and go to school and function when their circadian rhythm is at their lowest point. So instead of really getting a decent amount of sleep, they have this delay of their sleep and they're also having short sleep on school mornings as well. So the real point of this is to show that it's the delayed circadian rhythm that is the main contributor to the delayed sleep phase that we're seeing a lot in teenagers. And this is not just in Australia, this is worldwide. A lot of people might sort of point the finger at technology use, and this is why we also want to discuss this in a separate webinar. But when we've looked at the data, surprisingly for a lot of people, it's not technology use. It is certainly a biological contributor. So that was for teenagers. Now we'll look at contemporary diagnostic criteria for school-age children, and this also does apply to infants. But I will be focusing more on school-age children. So in the International Classification for Sleep Disorders, we have a single type of diagnostic criteria for chronic insomnia disorder. So this has been called a number of different types of disorders. In the previous edition, we actually had behavioral insomnia of childhood that was specific to an insomnia experience that occurs during infancy through to school age years. But now what they've done is that they've managed to bring all of these different diagnostic disorders for insomnia from the previous edition into one. So that is chronic insomnia disorder. So looking at the diagnostic criteria, Criterion A basically reports that there is some sort of difficulty with nighttime sleep disturbance. And you can see clearly in adults, you might have difficulty initiating sleep and maintaining sleep. But relevant to school-age children and indeed infants is that there is difficulty sleeping without parent or caregiver intervention. And what we see a lot of, and this is not just for infants, but also for school-age children, is that they really need their parent to be present. They need them to be close by in order to fall asleep. Insomnia is not just a nighttime experience, it's also a daytime experience. So the criterion B is really focused on associated daytime dysfunction that occurs at the same time. So you're getting fatigue, which can be quite common, say, for instance, with adults, but you can have attention, concentration, memory problems, impaired social, family, occupational, or academic performance. And that moves on to a whole range of other different types of daytime dysfunction. For criterion C, it really does suggest that the sleep complaints cannot be explained purely by inadequate sleep opportunity. So they have to have enough opportunity and time in bed. And they also need adequate circumstances. So they need to have a good sleep environment that's dark and quiet and comfortable for them. The sleep disturbance is quantified by being at least 3 times a week. And also criterion E says that the symptoms that are nighttime and daytime symptoms have been occurring for at least 3 months and not better explained by another sleep disorder. So this is really the diagnostic criteria that we see fits quite well, not only with infants, but also with school-age kids. And later on, I'll speak to the type of treatments that we've been doing that are the up-to-date evidence-based ones for school-age children with chronic insomnia disorder. One thing to note is that it's really important to understand that this is not just an insomnia disorder that occurs in adults, but it can be seen in all age groups. I know a lot of people have difficulty with trying to apply such a diagnosis for children and especially for younger children, but as seen here, it can be applied to all age groups. So moving on to the evidence-based treatment, and firstly, I'll have a look at the treatments for the delayed circadian rhythms. So this is an update on the best advice and strategies for using different types of treatments for different types of circadian rhythm disorders. And for us, we're focusing on delayed sleep phase. And focusing just on the bottom one there, which is saying that for the delayed sleep-wake phase disorder in children and adolescents, that the best treatment, the recommended treatment, is with post-awakening light therapy in conjunction with behavioural treatments. So this is what we're going to be focusing on in this seminar. So this was put out in conjunction with the American Academy of Sleep Medicine, the same people that produce the International Classification of Sleep Disorders. And it was published in one of their journals, which is the Journal of Clinical Sleep Medicine. And it was with a group of experts that managed to look at the literature and see what studies really qualified for their treatments for these different types of sleep issues, these circadian rhythm issues, and also looking at the quality of evidence. Unfortunately for this fourth dot point, this fourth recommendation, there was only one study that they could base this on. So clearly there was recommendations to have more research in this area. I'm happy to say though that the one study that they were able to apply to this was our study that was conducted here at Flinders University, which I will take you through. So this is just an example of the research outputs, I should say, that we've had from looking at delayed sleep-wake phase disorder, especially in young people and teenagers. And I'll take you not through all of these because I don't want to bombard you. So I'll just focus on some of these publications that we've had and take you through how the treatments have been beneficial for young people's sleep, but also for other secondary outcomes. So first is our study that we published in Sleep in 2011. And so this is a randomized control trial that the recommendation on the previous slide by the consensus sleep experts, that recommendation of post-awakening light therapy and behavioural treatment. So what we did is we looked at teenagers that had this delayed sleep phase disorder, and we had a hypothesis that really the major contributor would be a delayed circadian rhythm. So the idea was to try to provide bright light therapy. So I've got BLT there, really demonstrating this is bright light therapy that's applied in the morning. But because this condition has been going on for such a long period of time, that they have associated going to bed and attempting sleep and not being able to fall asleep with insomnia symptoms. So not necessarily looking at this in a pigeonholed sort of way, but really looking at there could be some overlap. So the idea was to try to provide a combination of CBT for insomnia, for their sleep onset insomnia that they would have at the start of the night, and then also applying bright light therapy to advance their delayed circadian rhythm. So in other words, trying to get their sleep timing earlier so that they could fall asleep earlier, wake up earlier, and be able to function better at school. So the treatment was conducted over 6 sessions over a period of 8 weeks. And compared to the control group, most of the sleep endpoints, the sleep outcomes improved. So we did find that teenagers were falling asleep earlier. They were taking less time to fall asleep, but more importantly, they were getting extra sleep on school nights. Now, when you do randomized controlled trials for a whole range of different sleep disorders, including adult insomnia, for adult insomnia, you're not necessarily getting large increases in the amount of sleep. Instead, what you're finding is you're probably reducing the amount of time that they are awake in bed. For this particular study, where we are advancing their sleep timing, we managed to give them extra sleep. At the end of treatment, we didn't see any significant increases or improvements, I should say, in their depressed mood, but in a follow-up at 6 months, we actually did find that they were having improved mood. So there's this delayed benefit in terms of their mood. Now, some of our interest in our research has been, okay, so which part of the treatment is effective? And clearly we've got 2 components here. Thankfully, we didn't have to conduct the study, the dismantling study, to find out which components were more effective. There was a group in Sweden that managed to do this for us. And so what they did is that they had 2 groups, one group that was provided with bright light therapy and cognitive behavior therapy for insomnia, like what we proposed and tested. And then they had a bright light therapy only group. Now, interestingly, there were no differences in the sleep endpoints for this particular study. So it says there's no extra benefit for providing cognitive behavior therapy for insomnia if you're just looking at the sleep outcomes. But the combined group that got both treatments did have better depression and anxiety. So as you can see, bright light therapy was effective in improving the sleep of the teenagers with delayed sleep phase disorder. But to provide extra benefit for their secondary outcomes of depression and anxiety, CBT looks to be indicated. So we performed a recent trial of DSPD treatment with bright light therapy this time, and bright light therapy only. It took 3 weeks of treatment. So this is where we're looking at a treatment that doesn't have that CBT component. And for this particular study, we were looking at the comparison between teenagers that had delayed sleep-wake phase disorder and good sleepers, and comparing them on certain traits, particularly traits that are akin to insomnia and insomnia symptoms. So compared to good sleepers, delayed sleep-wake phase disorder teens had more repetitive negative thinking, so that's more worry and rumination. They had more trait hyperarousal, reported more distress, more sleep monitoring. So for instance, being aware and monitoring things outside of themselves, I guess. So noises that were occurring, say outside the house, their temperature that they were experiencing, things that they really shouldn't be paying attention to because they should be trying to let go of their surroundings and trying to sleep, as well as sleep misperception. In this particular case, that's where they have a difference between when they think they fell asleep and what time objective measures found that they would fall asleep. And in this particular case, the objective measure was wrist actigraphy, which is the scientifically valid version of Fitbits and Garmins that you see around these days. So on the right-hand side, you can see here a clear difference at baseline pre-treatment between teenagers that have delayed sleep-wake phase disorder and good sleepers on the Insomnia Severity Index. So this is a common tool that's used to look at the efficacy of insomnia treatments, particularly for adults. And you can see here that there's a clearly high score there for teenagers that don't necessarily have an insomnia disorder, but certainly insomnia symptoms that are associated with their circadian rhythm disorder. So after therapy, not only can you see on the right-hand side there that therapy was able to improve insomnia symptoms, and keeping in mind this is bright light therapy only, we don't do any CBT techniques. We found earlier sleep onset time and decreased sleep latency, so that means they took less time to fall asleep, and also reduced sleep misperception, so they were more accurate in being able to determine when they fell asleep. We had reduced repetitive negative thinking, that's RNT. So keep that in mind, we're not doing cognitive therapy, we're not tackling these thoughts directly, but we're getting reduction in them just from doing bright light therapy. We also saw reduced physiological arousal, reduced distress, and improved functioning. So one of the take-home messages here is that chronobiological therapies are quick and effective. So after 3 sessions, not only can you get improvements in sleep, but also improvements on any associated insomnia symptoms. So in our original trial in 2011, we instructed teenagers to go outside and try to obtain natural light because that's the best source of getting bright light to do bright light therapy. Since then, we've had the production of artificial light sources. So you've got an example here on the lower right-hand side, the retimers. These were invented at Flinders University by my PhD mentors, Professor Leon Lack and Dr. Helen Wright. So in this more recent trial, when we did bright light therapy, we were getting teenagers to use the retimers only. So the retimers are a way for teenagers to be able to access bright light without leaving the house. And they provide green light, which is a short wavelength light and shown to be effective in changing the timing of circadian rhythms. We also managed to look in this more recent trial of performing bright light therapy at teenagers' cognitive performance. So looking at particular skills, cognitive abilities that often translate well to the school environment. So along with an increased sleep duration and decreased daytime sleepiness, we also saw improved short-term memory performance for these teenagers, as well as improved information processing. And another key thing is that they were able to return to school for those that were missing school, because what you will see, because of this mismatch in the timing of their sleep and when they need to get to school, that they're finding sometimes that they're having some days during the week where they are absolutely struggling to get to school. They'll probably get there late or miss entire days. And if the condition persists, then what usually happens is that they will start to miss weeks of school. And that's obviously when it gets incredibly serious. So I guess another take-home message here is that chronobiological therapies provide not only primary benefits to sleep, but also a lot of secondary benefits. And so this is one example, a case study of a teenager with delayed sleep phase disorder. We use sleep diaries for baseline measurements as well as during treatment. So this is a 15-year-old female's sleep diary. You can see here she's got quite severe sleep, because if we're looking here at the x-axis, which is midnight, she's turning off the lights here regularly at 11 o'clock, but she's learned that she's not going to fall asleep, so she actually goes to bed quite late, around the time when she's feeling really sleepy enough, and then she's falling asleep quite quickly. So these horizontal lines indicate when she is sleeping. But clearly here, you can see that when she should be at school in the morning between 9 and eventually 3:30 in the afternoon, she's sleeping for a significant majority of that time. Hence, she's not able to get to school. So after treatment, we were able to provide these chronobiological therapies. You can see here that she's, again, turning the lights off around about 10:30 to 11 o'clock, going to bed a lot sooner and able to sleep during the night, meaning that she's able to be awake during the day and attend school. So this is a common finding that we get, and it's certainly seen in the trials that we've performed. So that concludes the section on teenagers. Now I want to focus on school-age children, because when we opened up the Child and Adolescent Sleep Clinic about 15 years ago, we essentially just opened it up to school-age children and teenagers, and we just wanted to see what was going to come through the door and apply what sort of techniques that we had learned from seeing adults at the Repatriation Hospital Insomnia Clinic. And so in those initial 5 years, we managed to evaluate the treatments that we had essentially developed from our knowledge, not only of CBT for insomnia, but also our emerging knowledge of CBT for anxiety disorders. And we took out the components from both of these and merged them together for this particular issue, which was an insomnia disorder in school-age kids, where there was a real dependence on having the parents nearby in order to initiate or reinitiate sleep. So the major components for the CBT for insomnia was cognitive restructuring. So that's really dealing with the young person's thoughts and worries. Often they can be around safety and being a bit worried that they're the last people to fall asleep in the household and they have to protect the household, for example. Exposure therapy, which is really exposing the children to the gradual separation away from their parents so that they can be more successful in independently falling asleep. And to assist that process, also providing another major component, which is sleep restriction therapy, which is adopted from the adult CBT for insomnia techniques. So the combination of these three major components was done over 6 sessions, and we saw improvements in sleep, but also decreases in anxiety. Now, I guess we've had some suggestions that naturally we've got decreases in anxiety because a couple of these components like cognitive restructuring and exposure therapy are taken from the anxiety treatments. But one thing to note is that our treatment was for 6 sessions long. And in comparison, CBT for anxiety for school-age children, the standard therapy programs range from about 10 to 12 sessions. So we're getting improvements, equivalent improvements in anxiety in about half the amount of time. So it really did suggest that there was something about what we were doing that was unique and possibly accelerating that process. So what we ended up doing in subsequent trials, and we're attempting to publish these, is just focusing on sleep restriction therapy and providing that over a 2-week period and doing variations of this so we can understand the mechanism and how it works. And it's safe to say that we're certainly seeing improvements in their sleep within a 2-week period, but also seeing associated improvements in anxiety. So on the right-hand side here, this was our first randomized control trial that was published in 2011, combining these 3 components and basically developing CBT for insomnia for school-age children. So it's really been pioneered here, and it's one of the first in the world. So these trials have been performed in the Child and Adolescent Sleep Clinic. So it's a sleep clinic that's able to service the community and provide a benefit and a service for families. But we've also been passionate about evaluating what we do. It also serves to be a training clinic for future psychologists. So we're really trying to make it a one-stop shop, so to speak. We're able to provide services under Medicare, and given the COVID situation, not only can we do it face-to-face, but we can also perform this via telehealth, and we can also perform this not necessarily just in Adelaide and South Australia, but to rural, remote, and also other states. If you wish to find out more information before making a referral, by all means contact us on those details that are provided there. And certainly families can also contact us if they want to have a look at what we do and ask some more questions. So it's a place where it's pioneered a lot of new treatments. It's safe to say that when we look at our research trials, we're leading the research in this area in terms of sleep treatments for young people. And it's just been fantastic to be able to evolve these things and provide a high quality service for the community. So that really wraps this up. I might mention also that we have about 4 or 5 clinical psychologists at our clinic that can provide these services. They're also PhD qualified. They've done a PhD in sleep psychology, so they really know their stuff. So hopefully this has helped to improve your understanding of the different types of diagnostic systems and diagnoses that are out there for pediatric sleep disorders, and also update you to the evidence-based techniques. If you look in the comments, there's a link to the sleep and technology webinar that we also provide that goes for 30 minutes, but hopefully this seminar we've just provided you has also helped in terms of your own professional development. Thank you.